that first consultation is we're kind of creating a roadmap.
Yeah.
We get started and we have initial records, which when we started, 15 years ago, it was much more invasive. Big trays in the mouth, big gagging things, and now it's very simple. We used to block out 90 minutes for those visits, and now we can do them in essentially a half hour, which is
or less.
Or less, which is
our assistants are getting so good.
Oh, they're getting so good. Well, they've done it over and over and over again,
Right.
and the technology's tracked. It's just a better experience all around. You and I, we're all trained and certified for IV sedation, but we elect to bring in some extra help with CRNA, nurse anesthetist, which is helpful because it frees us up.
Well, for me, I really like that. Like you said, we used to do our own sedation, but I
Right.
really liked being able to focus just on the surgery, have an experienced anesthesiology partner there
Yep.
to handle that aspect, keep the patient safe, and then we can focus on 100% of our bandwidth focused on the surgery.
Well, when you have a surgery that's 4 or 5 hours long, it takes the whole morning. You really, it's important to keep people healthy, keep them monitored well, but we can focus on our craft, right? And we can really focus on getting the implants just right, the arch, the teeth in the right position, the occlusion. There's a lot of factors with the joint, the teeth, the positioning that need to be done right. There's sinuses. There's things that are managed well when we can focus on them.
Yeah.
And that frees us up to really do the best job. And when I hear about, and that'd be a question to ask when you go into a consultation, whether someone is going to have a sedation option, how that's going to be managed, if they have a third party doing the sedation for them. Frankly, if it was, again, my own mother, someone like that, I would truly want them in a controlled environment where they're going to be safe, and we know we're going to come out the other end with a good result.
Yeah. It's a serious matter, and I think that's, again, to the way we treat it is, if this was a family member, what would I do for them? And if you treat everybody that way, things work out. Things work out.
And it comes down to the surgery day, which we do review a lot of medical history. We want to make sure, again, that we're healthy and in a good position to do the surgery. Generally, we'll do a consultation. We'll reach out to your primary physician.
Yeah, I was going to say, and I think that's a good point. We do want to do a lot of time that consult with the primary care.
Yep.
And sometimes people get a little annoyed at that. It's extra work. I don't want to have to talk to my doctor. And we try to do everything on our side to make that process smooth.
Right.
But it really, at the end of the day, I think it's helping them understand that we're trying to take care of you. We want to make sure what we're doing is safe.
Yep.
We want to make sure that you don't have some hidden medical stuff that would lower the chances of success of the implants.
Exactly.
We want to get all that dialed in before we go into the surgery.
Well, that's a big philosophy on being DMDs versus the old DDSs. It's more a whole health focus, and I think that's the goal. Hey, we're going into the surgery. It's a pretty, invasive, serious surgery. We do it all the time. It's routine now, but we need to make sure that we are looking at other health things. So when we're finished, that you get a beautiful smile, but you're still healthy, and that everything goes smooth. Yeah. And fortunately, we've been able to never have any issues. And that's thousands of implants over years and years that have all gone smoothly. But a lot of that's because of the processes that have been set up. So I think that's important for someone to, when they're looking at it, to make sure, hey, what do you have to manage my condition? If they have diabetes, or if they have some other condition, that like a heart condition, or they're taking some medications, how does that affect the process? And to ask those questions. And we'll actually have our nurse anesthetist, we'll talk to you about it, but then we also have the nurse call you the day before to review medical history to make sure everything's on the up and up as we go into it.
Yeah, and I think that's, a lot of our patients are, because of their teeth or in relation.
Yep.
It's a chicken or egg scenario often, but not the most healthy, in the most healthy situation when they need this procedure. What we call the polypharmy, which, means just taking a lot of different prescriptions potentially,
Sure.
a lot of different conditions. And we want to manage with best practices.
Exactly. When we get to the day of surgery, it's great. We've reviewed medical history, we've previewed the bone. We've looked at the 3D X-ray together on the screen. We have a plan. The nurse anesthetist is there. We are there as dentists. We have a whole team kind of supporting us in this process, multiple dental assistants, and a whole setup in a surgery suite dedicated to these bigger procedures, which is really nice. You come in and things flow well. There's a little more room in those operatories. And when you come in, that's when we get the process started.
Well, yeah, as you know, I do a lot of teaching.
Yes, of course.
Over the shoulder training for other dentists. And I love cooking in my own kitchen, so to speak.
Oh, for sure.
When I can be in my surgical suite and have my assistants and the flow of it, things just, like you said, it's like an orchestra, like a concert, right? Things flow. When I go do over the shoulder training in someone else's facility, oh, where's this, where's that? And, you don't get the same outcome.
It's just nice. It's a dance with the assistants, with the team, with the anesthesiologist, that you work in concert together. I love that. And that way things go really smooth. And frankly, the time of surgery is shorter because it goes so smooth. And frankly, when you're getting surgeries done, shorter surgeries mean better recoveries, faster recoveries, less post-op pain. And we try to stack the deck so that people have outcomes that they're really happy with.
Yeah.
So they
Well, let's talk a little bit about the surgery time, because that's another question I get all the time.
all the time.
Doc, how long is this going to take? And we'll give a ballpark of 2 hours or so per arch.
Yep.
But I always tell my patient it's going to take as much time as I need to do a good job.
That's right.
Right.
Well, sure.
Every situation is different. We have some that are straightforward and we can maybe move them a little more quickly, but always deliberately, right? I never want to be moving so fast that I don't get the best outcome.
Of course.
And I don't want to, like, on the other hand, belabor it, have, like you said, a disorganized situation where they're looking for stuff or we're stalled out during surgery, because it's not good to have the sedation longer than needed or have the surgical site open more time than it needs to be. So I think, again, it's trying to find that perfect amount of time where we take our time to move deliberately. It's smooth as slow, slow as fast kind of thing situation.
I love that quote. Yep. So I'm the patient. How long does it take, Doc?
It's going to take the time we need to do a good job.
All right. And which is average?
Yeah, you average about 2 hours an arch.
2 hours an arch. There you go. Great. So when we get going, we stack the deck again to get a good outcome. And what that oftentimes looks like is we have an IV in there. There's different medications that are used. Propofol is a common one that we'll use, but we'll review and make sure that's the right drug for the sedation for you. Mm-hmm. While we're under sedation, we'll generally draw some blood as well, and we'll spin it in a centrifuge. Some people are familiar with PRP or PRF, and what we'll spin it down to is platelet-rich fibrin or PRF. And I'm a big nerd. I think this stuff is so cool. It's your own cells.
Yeah. I mean, I've been doing the PRF since 2015.
Right.
And it's one of those things that I don't know why everybody's not doing it. I mean, we're literally taking the patient's own blood, spinning it down to their white blood cells.
Yep.
And what that does is it concentrates those self-healing cells in the area. We create that membrane, place it in our surgical site. It lowers the incidence of infection almost to zero. It speeds up the healing. I mean,
post-op pain is less.
Yeah, really the only downside
angiogenesis.
Is having the equipment and the training in office to do it.
But once you do, I mean, there's really very minimal cost to it in the surgery setup, right? Once you're set up, you have this anesthesia going, you draw some blood, you spin it down.
Yeah, well, that's what I say. All the expense, I think, is in the equipment, the training, then just the logistics of managing that as part of the surgery.
Yep. But the benefits are just fantastic.
Yeah, it's a no-brainer.
It's a no-brainer. And for wisdom teeth, but especially for full arches or even single sometimes, we'll get a membrane of PRF, we'll lay it in there. And not everyone's doing it, which is shocking. There's so much research. Well, your friends, you've done some CE teaching and things.
Yeah, I've taught with Rick Myron
Rick
quite
Myron,
a bit.
yeah,
He's
exactly.
The world expert in PRF.
He really is. He's studied in Bern, in Switzerland and kind of around the world and lectured, and the guy is phenomenal.
Yeah. Talking about nerds, he's a total nerd.
And he's got quite the hairdo. You should see this guy.
I just love the work he's done, though. He's dedicated.
He's very dedicated.
He's dedicated probably a decade of his life to this one niche, and he's improved the science.
Well, he's got the whole process down. We got exact times and RPMs for the centrifuge, the swinging buckets.
When I first taught with him, probably 5 years ago, we used to use a different
That's
brand,
right.
different system. And after being on the lecture circuit with him, I'm like, Rick, we're switching over to all your stuff. Because,
you have to.
He's gone through that
It's all research.
exercise of, it's all research based.
Yep. And it works so well. But that's one thing we do, PRF, which is phenomenal. And it really stacks the deck in a really, for healing, for the best outcome. We also will oftentimes put pain medications in the IV.
Right.
And there's also a steroid we'll use.
Yeah. And, I like to inject that steroid directly just because it'll stick around longer.
Exactly. So when you have a steroid on deck, pain medications, PRF, long-lasting anesthetic, when people come out of a surgery, yes, you're post-surgical. You don't remember a whole lot from that first day. But the first 2-3 days, when you stay ahead of the pain by taking your medications and stacking the deck with all these things, is generally not too bad.
Yeah, and again, another common question, right? We're talking about all the questions is, Doc, how long is it going to hurt?
Yep.
How long am I going to be? How much is it going to hurt? How long am I going to be out of? Need to take off for my job or for rest? And again, the answer, unfortunately, is it depends. But on average, I'm always flabbergasted by how minimal the post-op is compared to what you would think it would be.
Yep.
We have some patients on the one end of the spectrum that come in. They say, "Hey, Doc, I didn't really listen to what you said. I went back to work the next day, and I actually feel great." So we have that on one end. We do have the others that are more kind of the hyper responders that can be sore, and they do need to come in. They come in for that week post-op, and we need to prescribe more pain meds because they're still sore, and that can stretch out for a couple of weeks.
Right.
But most people are somewhere in the middle where, like you said, they're sore for a few days. They stay ahead of the pain, and then things get better. And generally, it's not like all of anything healing. It's not like a light switch switches off, but the dimmer switch where it just gets better and better.
It's better and better. I will get occasionally where the IV steroids will wear off, and that's generally around day 4. So sometimes just around day 4, people say, "Hey, Doc, I'm not feeling so good today," and that's when the steroid is worn off. And after that, they climb out of it, and by the time you hit a week, they're usually doing pretty darn good.
Yep.
Yeah.
Yeah, that's generally. Let's talk about some of the more common post-surgical complications we do see. Just because, I think this is educational, and
that's
we want to hit it all.
Really important.
I think a big one that can surprise patients sometimes is bruising.
Bruising is big, yeah.
And what's interesting about the bruising is it's not necessarily related to pain or to even what we do, right? To surgical technique. Again, I could have 2 patients, and I work on the one. I say, "Man, this was a hard surgery. We had them open longer. We had to be a little bit more invasive to get good anchorage of the implants, to get a good outcome."
Right.
I think this person's going to be, it's going to be a little rough for them healing. I'll see them back at their post-op, and they'll be, "It's great, Doc. It's awesome." And then you have that one where everything goes just perfectly right.
It goes quick.
Yeah, you're in. Everything is works out perfectly, and you're like, "Oh, this person's going to be great." Then you see them back, and they've got some bruising under the eyes, down into the chin, and there's like, "Doc, what did you do to me?" And you're like.
Well, generally, what's the rule of thumb? If you bruise easily, you'll probably bruise.
Yeah.
If you're not one that bruises that frequently, you probably won't bruise. It really depends on the individual.
Again, our experienced team, I often have it where I come in and I see the bruising and I'm ready for that conversation. They say, "Oh, no, your assistant at the consult told me already that this would happen because I'm on a blood thinner."
Right.
I mean, our team knows the process so well.
Certain things will
that they often stay ahead of that. But
have you had much success with patients using arnica, like some natural remedies to prevent bruising or help with that?
Yeah, they're not everybody wants to do it, but I think the arnica does help. There's also that product Stella Life,
right?
That I've had good results with and heard good feedback from patients on that. So I think there are some natural remedy things that help. I think the big one is the ice packs.
I was gonna bring that up. Yeah.
If they can use those ice packs 15 minutes on, 15 minutes off for that first day after, keep the swelling down. It seems to also limit the bruising.
And we have the head wraps we're using now. We use them constantly, and 15 on, 15 off. But that helps hold it right in the position. But that makes a big difference. Help with some of that swelling.
Yeah.
It's the thing we've heard forever. And the other common thing is just like a warm saltwater rinse, very gentle. We want to do everything gently. But when you do a warm saltwater rinse, something grandma's taught us for 100 years.
Yeah, I think it's the first few days, just leave it alone. Right?
The first couple of days, for sure. Yeah. I agree with that.
Yeah, we want those cloths to stabilize everything, but then, from there, absolutely. Not too hot, not cold water, because that doesn't feel good, but just that lukewarm, saltwater rinse.
And just kind of gently turn your head left, turn it right, drool it out. But it really helps the site, the soft tissue. Things tend to do better for those who I've seen following that protocol versus not.
Yeah. Well, let's talk about the pain management too, since we're here.
Yeah, great.
What typically do we do? Every patient, again, is different, and it depends on their medical history, other things they're taking. But generally, what we like to do is just a basic antibiotic to help with, and typically that's amoxicillin. Again, could vary. But then I really love the pain pack protocol. Been using that for the last few years. It was developed by an oral surgeon originally, right, for the wisdom teeth. But we know that we have this opioid epidemic.
It's a real thing. And I worked at oral surgery clinic back in the early 2000s, probably 2003. It was Vicodin, like candy. And that was the protocol. That's just what you did. But like you said, it's turned into an epidemic. You've had some issues, and we've seen that nationwide.
Well, and we don't want to be part of it. We want our patients to have good pain control, and we want to take care of them, but we don't want to be part of the problem.
Of course not, right.
Or create addicts, or I don't want that on my conscience.
Of course not.
So the pain pack protocol, I think, is a great kind of middle ground option where we start with Tylenol and ibuprofen together.
Correct.
Which in the pain studies for dental pain have proven to be more effective than an opioid by itself. But we use that escalating dosage, right? We start with the ibuprofen and the Tylenol. If we can stay on that consistently and have that pain managed, then we use just a plain opioid, usually oxycodone, for breakthrough pain. So most of our patients, they use non-opioid for the bulk of their pain management, and then they might take an oxycodone to help them sleep.
Well, just for those who may not be familiar, what is a Vicodin versus having it separated out? And I think that's the basic element. Is a Vicodin is the opioid plus maybe the acetaminophen or Tylenol combined.
The problem with that combination, and I don't know if this is nefarious from the drug industry or if it's just they weren't smart enough or well versed enough in the application, but in the Vicodin you have too high of a dose of the opioid and too low of a dose of the acetaminophen. Right? So you're going to max out on the opioid, which has all the negative effects. Obviously, addiction being number one, but also nasty short-term effects, nausea, constipation, just nasty
stuff.
Being out of your mind a little bit.
Loopy.
Yeah, just the way it makes you feel. It's not the best combination.
Separate them out.
Yeah,
and you might not even need that
at
all. And like you said, the research study supports that you can get the management you need off of these over-the-counter ibuprofen Tylenol things. And I think it might be worth pointing out that they work in different pain systems in our body.
Yeah.
And so when you take them in tandem, they actually are more effective, right? It's an additive response versus taking just one or just the other. So when possible, and there are exceptions where people can't take one or the other, but when you can do them together in tandem, they can manage most all the dental pain after a dental procedure like a dental implant surgery.
Yeah, and I do see that too, right? With patients, if for whatever reason they're contraindicated, they've got a ulcer or whatever, and they can't do the ibuprofen, and Tylenol ibuprofen, and they have to use just an opioid. It just isn't. I mean, we get them through it, but it's just not as good of a pain management situation.
It's not. Yeah, but that works so well. This pain pack protocol, we print it out on a sheet of paper. You can track it. You can write your times. It has it all listed out for you. Oftentimes, patients I'm working with will find it works well at night to take the opioid if they need it. Generally, when they lay down, that's when it really acts up.
And it's also, they're just, that's all they focus on. You go to sleep and you don't have distraction of everything going on. And the pain, it's an experience, right? Pain is an experience. It's not just necessarily smash my thumb with a hammer and it hurts. The same for everybody. There's the emotional aspect tied into it, anxiety around if it's going to hurt. There's the amount of time that they've been in pain, the location in the body. So it's this whole it's an experience that's it's psychosomatic, right? It's the psychology and the physical all mixed together. So it's a very different experience for everybody.
That's exactly right. The pain is manageable with the pain pack protocol. I've seen.
Yeah, and that's, I know we kind of went deep there for a minute.
That's okay.
On the rabbit hole, but I think it's maybe helpful for some people listening to know why we've arrived here. But yeah, when we start with the non-opioids and we add that as an escalating dose, we really do see patients come in and say, hey, it wasn't that bad, doc.
It wasn't that bad. And a week later, they're coming out of it. Generally, when you get later into the week, another thing I'll notice are people say, I feel a tickle. Something's tickling me in here. What is that?
Yeah, sutures.
It's a suture, a little whisker in there. But oftentimes they are dissolvable sutures. They will start to release, and you'll feel some of those tickling sensations, if you will, which is supposed to happen.
Right.
Be rest assured that it's doing its job. It's supposed to release. It's generally day 5, 6, 7, around a week that we start to see some of those sutures releasing, which is normal.
Yeah, and we use a little more complex suture process, right?
Oh, sure.
What I call the two-step.
The two-step.
Right, but it's a continuous running suture, which is nice because it's less little ends and less knots, more comfortable for the patient. We get better closure
Correct.
of the wound.
Yep.
Because
Both
we're able
together.
to use a horizontal mattress with the continuous run over the top of it.
That's right.
But I do tell my patients, it's like, if you get that little string, don't yank on it, right?
Don't yank on
Don't
it.
unravel my sweater
That's right.
up in there. So what we want to do instead is, if you have a little one that's tickling you, come in and see us. We're happy to handle it. Or take a little pair of nail scissors, just clip off that little thing and leave the rest of it alone.
Leave the rest alone.
The rest will dissolve out when it's ready.
That's right. No, it works pretty well. And generally, when I'm having the 1 week post-op, I'll take the sutures out. They've done their job at 1 week. Right. And if they're in
longer... Which is incredible, right?
Which is incredible.
Isn't it incredible how quickly the mouth heals
we got these carotids coming up, our brain, all this important anatomy in our skull here. But we're blessed with, we're not working on our feet here, fortunately.
Good
things heal really quickly in our mouth, especially when you stack PRF and all these things along with it. They just tend to heal pretty well. Mm-hmm. We don't get scar tissue like we would in other parts of the body in the mouth, which is maybe worth mentioning. Mm-hmm. Things heal pretty well. It's very forgiving.